So out of the cath lab business, out of clinics, back to the basics. Most often we stay busy in cardiovascular interventions and different interventions, but we should remind ourselves that the basics lies in the silent, in those which are silent and those which we don't deal well with. So dyslipidemia and atherosclerotic cardiovascular disease, I'm going to go in the next 10 minutes through the guidelines. 10 minutes are not enough to explain the guidelines, but I'll just go walk through the guidelines and explain some of the highlights. ASCVD, we know, is the leading cause of death worldwide, 18 million deaths per year globally. Dyslipidemia is a modifiable key risk factor for ASCVD. We know what are the other risk factors, and we know when did the risk factors came into business through Framingham Heart Study, the first time when risk factors were defined in 1961, and since then many risk factors have evolved. Those risk factors which are modifiable, among them cholesterol stays at number 3, although it's written on top. We know raised blood pressure kills 10.8 million people globally, air pollution 4.8, and dyslipidemia, silent killer, comes third in the business. These all are modifiable. Now the good news, the good thing about this slide is these risk factors are modifiable. So we know what is the role of these risk factors. If uncontrolled, they lead to thrombotic cardiovascular events, and from our basics we know endothelial injury is the first thing that happens, and most of the drugs, most of the molecules their focus is on endothelial stabilization, lead to lipid accumulation, chronic inflammation, plaque formation, plaque rupture, and in them the main engine, the main players are ApoB containing lipoproteins LDL, VLDL, lipoprotein little a, which serve as a structural protein for all atherogenic lipoproteins driving cholesterol deposition in the arterial wall. So we know how do you categorize our patient. The risk is based on Framingham Heart Study, atherosclerotic cardiovascular disease. We risk stratify our patient as having 10-year risk of 30%, more than 20%, 10 to 20%, less than 10%. So those who got the next year 10-year risk of less than 10%, we label them as low risk, and going up, if the risk is more than 30%, we label them as extreme risk. So who are those who are at extreme risk? Those patients who got progressive ASCVD, including unstable angina, individuals after achieving an LDL less than 70 milligram, or those with established clinical cardiovascular disease in individuals with diabetes, stage 3 or 4 CKD, heterozygous familial hypercholesterolemia, history of premature ASCVD. So what are the LDL targets for them? For those who are having extreme risk, LDL has to be less than 55 milligram per dl, and non-HDL has to be less than 80 milligram per dl. And similarly, in those with very high risk, less than 70, those at high risk, less than 100, and those who are having low risk, who are having their LDL needs to be less than 130 milligram per dl. But how often we check these lipids in our clinical practice, and do we follow the guidelines? So the guidelines say, the AHA guidelines, they reaffirm the central role of LDL reduction as the cornerstone of ASCVD risk mitigation. And we know we attend most of these patients when they come with MI, with stroke, with these complications, we entertain them. There's a stronger advocacy for early initiation and intensification of lipid-lowering therapy, particularly in patients with established chronic coronary disease. It recognizes also the incremental prognostic value of ApoB and lipoprotein A in risk refinement, especially in individuals with borderline LDL cholesterol values or residual risk despite optimal medical therapy. The guidelines also expands recommendations for combination therapy. We know layered therapy. Most often we stay with high intensity statin and without checking the targets that needs to be checked, the targets that need to be achieved, and following the guidelines. If we are not bringing those targets to the according to the risk, probably we are not doing justice with the patient. Integrating ezetimibe and PCSK9 inhibitors, they need to be started earlier in treatment algorithms if the targets are not achieved. Introduction of bempedoic acid as a guideline endorsed option, particularly in patients with statin intolerance, patients not at LDL goal, despite maximally tolerated therapy and based on robust outcome data from the CLEAR outcome trials. They also emphasized lifetime exposure to LDL cholesterol. The lower, the longer, the better, as a determinant of cumulative cardiovascular risk. Now, the emphasis is on a movement towards personalized layered lipid lowering regimens, including non-statin therapies such as bempedoic acid, to address both therapeutic inertia and statin intolerance. And what is therapeutic inertia? When, despite knowing that these high LDLs are dangerous, despite knowing these low HDL are not friendly, we still fail to achieve the target. This is what therapeutic inertia is called. Factors can be both on the side of the patient as well as the clinician. The guideline also reflects paradigm shift from monotherapy to early combination strategies based on a risk tier, lipid response, and tolerance. And lipid, a couple of the terms that we used, layered lipid lowering regimens. And by layered lipid lowering regimens, out of the just statin group, we have to bring into business azitamide, PCSK9 inhibitors, and at times, although not available, inclisiran and all those with which we can achieve our targets. So the foundation still, the foundational drug still remains statins. Azitamide are the options when we don't achieve our targets. They need to be started early, after 6 to 8 weeks if we are not reaching the targets, and bempedoic acid, PCSK9 inhibitors. In fact, in the guideline, PCSK9 inhibitors are the frontliners if we don't achieve the targets. But in our clinical scenario, I believe because of their availability of these monoclonal antibodies, bempedoic acid is a good option. So there are different risk factors, scoring models used, like in US, the ASCVD 10-year risk scores, which risk stratifies our patient, and in European guidelines, the Euroscore 2 and Euroscore 2-OP, considering the different ages. And Q risk is something used by the NICE guidelines for risk stratifying our patients. Q risk is something more elaborative, takes into account many other aspects, incorporate broader, the mental illness, the corticosteroids, CKD, and all those which have not been, which are not part of the ASCVD and SCORE guidelines. So, other than these known risk factors, what are the risk enhancers? The risk enhancers in borderline or intermediate risk patients, in them, if the risk enhancers are present, they reclassify these risks. High sensitivity C-reactive protein, we are well aware of them, is a marker of residual inflammatory risk. Lipoprotein little a is an independent genetic marker of risk, and similarly, coronary artery calcium score, that is very much come into the business. It's a CT-based direct measure of subclinical atherosclerosis, and family history, especially premature family history in men less than 55 and in women less than 65. That they also need to be considered. If they are there, they are further risk enhancers. And somebody who is low risk, his risk becomes intermediate. And somebody who's intermediate risk, if these risk enhancers are there, the risk increases further. So LDL cholesterol still the primary target in ASCVD. There's a robust dose-dependent relationship established through Mendelian randomized trials, through multiple randomized controlled trials done on different statins and non-statin groups, whether we talk of PROVE-8, IMPROVE-8 or DESE trials on the new molecules, 4-year trials, CLEAR outcomes on bempedoic acid, TNT 2005. All these trials are suggesting that LDL still remains the cornerstone for these. So next to addressing this, beyond LDL, we have to look on triglyceride. Triglyceride, we know if it is more than 500, they need treatment. But in those cases where there's low HDL, we have to treat triglyceride. The therapies remain statin, icosapent ethyl, fibrates. These are the drugs which can be treated. And HDL is something that also needs to be addressed beyond lipid lowering. So it's a risk marker, but not a treatment target. Pharmacologic HDL raising, we know, has failed to reduce ASCVD. Focus needs to be on lifestyle optimization, weight loss, regular exercise, smoking cessation. And emerging biomarkers and therapies in lipid management, we know the next frontier is lipoprotein A, which is genetically determined, elevated in 20 to 30% of global population. It is a stronger independent predictor of ASCVD and aortic valve disease. No approved therapy yet, but promising trial is coming on prelacarsen. Similarly, the inclisiran, we know inclisiran is something that also deals with with PCSK9 inhibitors. It is a slow interfering RNA-based PCSK9 synthesis inhibitor. In fact, it silences PCSK9 and increases the activity on LDL receptors. Biannual dosing after initial dosing, sustained LDL cholesterol reduction up to 50%, improved adherence in real-world settings shown in Orion trials. We know inclisiran, although not available, is a drug which is very friendly. Its use is easy, biannually used. Injectable one. Similarly, bempedoic acid, statin alternative, aid, more often used as an aid-on therapy, and in those patients where statins are intolerant. LDL cholesterol reduction of 18 to 25% liver activated, not associated with myopathy, validated by clear outcome trials, reduced MACE in statin intolerant patients. So I'm just going to go through. It's not just about the numbers. It's not just about to reduce the number. It's about comprehensive approach of ASCVD prevention beyond lipid management. Not only the lipids, we have to drop it down, but also we have to achieve blood pressure targets, glycemic control, as well explained by Dr. Fazal, especially those patients which those molecules SGLT2 and GLP-1 receptor antagonists, they have got cardiovascular benefits. They need to be on top of priority in patients having ischemic heart disease. At antithrombotic therapy, aspirin, dual antiplatelets, lifestyle behavior, inflammation, and residual risk. So our targets needs to be holistic, not just reducing the numbers. What is the Pakistani landscape? I'm just going to go through all these data, and the data is not better than rest of the world. Our data is probably poorer than them. The high rates of premature CAD, metabolic syndrome, limited access to lipid-lowering therapies. These are the challenges we are having. Need for national screening programs and subsidized lipid clinics. We see when we go through all these different ages data taken from different parts of the country, we see that premature coronary artery disease is much common as compared to rest. And we know being South Asian itself is a risk factor. We all know. So concluding my slides, the take-home messages: LDL cholesterol reduction remains foundational because the robust dose-dependent causal link with ASCVD, the lower, the longer, the better. No threshold for harm identified. From monotherapy to early combination, guidelines now endorse layered lipid-lowering statin, ezetimibe, PCSK9 inhibitors, bempedoic acid, inclisiran tailored to risk and tolerance. Bempedoic acid fills the crucial gap of an oral liver-selective agent that lowers LDL cholesterol without muscle effects, validated in statin-intolerant populations. So risk stratification is evolving. Use of risk enhancers, lipoprotein A, hsCRP, coronary artery calcium score often refines individual risk, enabling more precise interventions. ASCVD prevention, multidimensional lipid control is vital, but optimal care also addresses blood pressure, glycemia, thrombosis, and lifestyle, integrated for sustained outcomes. The future is personalized. Our treatment needs to be personalized, preventive, and proactive. The shift is towards earlier, more aggressive, and individualized therapy informed by genetics, biomarkers, and lifetime risk exposure. So with this, I thank you very much for your patient hearing. And before I leave the stage, invitation at the 55th CardioCon, which will be from 21st to 23rd November, is going to be held in Quetta. So you all are invited. So you all are invited for that, and inshallah it will be a memorable conference. All of you, from the core of our hearts, invitation for all of you. And little concerns, I think I can see Quetta is a peaceful place. If anyone has heard anything happening in Quetta, I think, I don't remember during the last 1 year anything such. The fear is there. The fear raised by some of our colleagues, because it's a limited environment, so that's I'm talking openly. So come to Quetta, inshallah. Our hospitality, inshallah, you would enjoy the 55th CardioCon in Quetta, and I hope there'll be a big participation from every part of the country. Thank you very much.